Greetings, everyone. Welcome to the second part of our new webinar series in partnership with the Montana Natural History Center and the University of Montana, The Age of the Coronapocene. I'm Jennifer Robinson, Education Director for the Montana Natural History Center and host of this webinar series. Our co-host today will again be Drew Lefebvre, the Montana Natural History Center Museum Programs Coordinator. She will be working in the background and available to answer questions and address comments using the chat box. Please let her know if you have any technical difficulties or questions during the webinar. Similar to last week's webinar, this one will also again be supported by closed caption capabilities. The wonderful Caroline Habish will be working in the background again to provide text for our speech if you need assistance in following along with the program. Drew is going to put the link for closed captioning in the chat box. This will open up a separate window when you click on it or go to that link where you will be able to read what is being said on screen as we are speaking. Please note that the cap for closed caption is only at 50 individuals, so please only use this assistance if you need it, so we have enough space for all of those who require closed caption assistance. Throughout the webinar, we'll keep reposting that link into the chat box for those of you who join late. Back with us today are members of our expert panel of scientists and educators from the University of Montana, and they're ready and excited to start more discussions about the science behind the novel coronavirus, COVID-19. As a reminder, our panel are not medical doctors and will not attempt to try or diagnose symptoms in this program. Later in the program, the audience will have an opportunity to ask our panel questions about the virus and living with COVID-19, but note that we will not be taking questions and questions if you're seeking medical advice. Please seek your own medical help if you have questions or concerns about your health. Back with us today, we have Assistant Professor Angela Lewis, who works in population and disease ecology at the University of Montana. She specializes in studying the epidemiology of infectious diseases, and today we'll be discussing how epidemics spread and what flattening the curve really means. Also with us today is a new member of our panel, Assistant Professor Erin Semmens of epidemiology in the School of Public and Community Health Sciences at the University of Montana. Dr. Semmens is an environmental epidemiologist. Her primary research emphasis is on the health effects of environmental exposures, particularly relevant to rural populations. During the question and answer portion of the webinar, we will also be joined by Assistant Professor Brandon Cooper from the Division on Biological Sciences at the University of Montana. He is an evolutionary geneticist and population biologist who studies host microbe interactions and conducts research on bacteria used to control human disease transmission. Today's webinar will dive deeper into the science behind COVID-19 and focus specifically on the epidemiology and science behind what it means to flatten the curve. Angela Lewis will start us off, and then we'll turn it over to Dr. Semmens before opening up for a question and answer session. During the Q&A, you will be able to ask the panelists questions and have them answered live. To ask questions, you can use the chat box or the Q&A feature of Zoom. To let us know of any technical difficulties or to communicate with the co-host, please use the chat box. Please note that any comments or questions you put in the chat box are only visible to the hosts and panelists and will not be viewed by any other attendees to the webinar. Let's go ahead and try to use that feature now for the chat box. Go ahead and type into the chat box where you're tuning in from. Great, looks like we got some folks from Missoula, Polson, Lolo. Ooh, we've even got some folks from Iowa. That's exciting. Arizona, nice, that's quite a ways away. Thanks for tuning in. Some more from Missoula, British Columbia, fantastic. Carrie's back from Utah, awesome. Butte, Anaconda. Great, thanks for sharing where it is that you're tuning in from. Okay, let's jump in and get started. I'm going to turn it over to Angela Lewis. Can you start us off and tell us more about how epidemics spread and what flattening the curve means?
Sure. So when we study how viruses spread through populations, we don't count the number of virus particles There's just too many to count. So instead, we group people into different categories with respect to their status. So we'll have some individuals who are uninfected but susceptible to infection. So they haven't been infected yet, but they can get infected and get sick. And then we have some people who are sick, they're infected, and they're contagious and can spread that infection to others. Or people could be recovered and immune. So they've been infected and now they've recovered, they're no longer sick and no longer contagious, and now they're immune. So if they're exposed to it again, they can't get infected again. And over the course of an epidemic, individuals move through these different categories. In the beginning of an outbreak, everyone is susceptible. No one is infected, but everyone could get infected. And then if we have one infected person coming into the population, that infected person could interact with susceptible people, like cough on them, and make them become infected. And so then those susceptible people are gonna move, they're gonna leave that susceptible class and move into the infected class. And then people are in the infected class for as long as they're sick and contagious. And then eventually they either die or they recover, most recover. And then when they're in the recovered class, they've left the infected class, they're no longer contagious, they can't spread the infection anymore, and they can't get it again. So we can describe how these different categories of people, how their numbers change over time. So if we look at that, so I'm going to look at how things are changing over time here on this x-axis. And first, let's look at how the infected people, how the number of infected people over time changes. So first, when an infection is introduced, we have it coming into the population, one infection starts to spread, and in the beginning it looks really slow, and then it starts to shoot up. So this looks like it's not really growing in this phase, but really it is. It looks like it shoots up really fast, but it is experiencing growth through this whole phase, and what we call that is exponential growth. And the rate at which these cases are increasing is determined by this quantity we call R0. So that's an R with a subscript 0, and that 0 is not, N-A-U-G-H-T, as in nothing. And we put a 0 there because it's talking about time 0, the beginning of an epidemic. And what that quantity tells us is the average number of people that each infected person infects. That only applies to the early stages of an epidemic, so right in the beginning at time 0, and I'll explain why that is in a minute. So for example, if R0 is equal to 2, that means that one infected person comes into a population, they cough on and infect 2 others. Each of those 2 then goes on to infect 2 others. So if this happens, so for example, this particular person is sick, they got these 2 people sick, and by a week later, they're not contagious anymore, but these 2 people are now sick and contagious. And so this spread will continue where each person that's infected is infecting 2 others and 2 others, and you can see how this can really balloon out in no time at all. So we started with 1 person, and now after about 5 weeks, we have 32 people who are infected. If R0 had been 3 here, 1 person would have been infecting 3 others, and then those 3 infecting 3 others. And you could see that the rate of increase would be really high then. But what we see, this exponential growth, it looks really slow in the beginning. So from here to here, we only have 1 more case than we started with. From here to here, it's only 2 more, and from here to here, it's 4. But once you start going, it really starts to balloon out. And so it looks really slow in the beginning, but it is growing. So here's the difference between how an R0 of 2 would look over time compared to an R0 of 3. So here we've got, it looks really slow, but it is increasing over the time, and now it's starting to shoot up, but it's going to shoot up at a much faster rate when we have an R0 of 3. So each person is infecting 3 others. So you can see how R0 could have a huge impact on how fast an infection spreads through a population. So if we're watching how infection is spreading through this population, the number of infected people is increasing over time. It starts to shoot up, growing exponentially. But if we continue to watch it, what we see is that it starts to slow down and flatten out here. And then if we continue to watch it even more for a longer period of time, we see that eventually the cases will start to drop off. And so that happens naturally, that happens without any intervention for all epidemics, for these types of epidemics. And why does that happen? That happens because as the number of infected people is increasing, the number of susceptible people is decreasing because people have left that susceptible class and they've moved into the infected class. So they've left these S's and moved into this red I. And so that means that here in the beginning of the epidemic, if there's an R naught of 2 and I'm infected, I'm going to cough on 2 others and get both of those people infected because everyone is susceptible at that point. But once the epidemic starts to take off and you're here in this phase, things are slowing down because not everyone that you cough on is susceptible anymore. Some of them are infected already, or they've already been infected in the past and now they're recovered and they can't get sick again. And so that's why the number of cases drops off over time. And so if we continue to watch this, we see that naturally the infection will die out. Because your susceptible class gets really low and there just aren't as many people around left to infect. And so I told you that R naught is how many people get infected by each infected person, but it applies to only the beginning of the epidemic when most people are still susceptible. If you're talking about after an epidemic has taken off and the susceptible levels have started to drop, we talk about a quantity just called R or RE instead of with that 0 on the bottom. And so that's the number of people that get infected from each person after an outbreak has taken off. And you can see that in this range, because the cases are still increasing, that means that each person is infecting at least one other. They're infecting more than one other, or you wouldn't see an increase in cases. But at this point where things are leveling out at the top, there we have an R of 1. So each person is only infecting one other, and that person is infecting one other. And so that means you've got this sort of steady level of infection. And then after that, R naught is less than 1. And so you get a decrease in cases because each person is infecting less than one other. And so the outbreak starts to die down. So we could also look at what's happening to the recovered class in addition to this. So you'll see that as the outbreak is carrying on, the number of recovered people is increasing over time because the infected people, so there's just a bit of a lag here between the infected class and the recovered because this is how long people are infected. And then they move into that recovered class. So you can kind of monitor this recovered class as a measure of cumulative infections over time. And you can see in this particular example, most of the population gets infected by the end. So this is only slightly lower than the population size that we started with. So exactly how large an outbreak is going to be at the peak and how many cumulative cases there are determined by R naught. So if R naught is equal to 4, then what we see, this is a pretty high R naught. So each person is infecting 4 others, and those 4 are infecting 4 others. And the infection spreads really fast. It shoots right up, it reaches a very high peak, and then drops off very quickly. And so the whole outbreak only takes maybe a month and a half. As you decrease R naught, you see that the peak number of cases declines, but the outbreak starts to take longer. So as we decrease R naught, we see that the peak number of cases, the number of cases at any one time goes down. The outbreaks take longer, but also the total population that ends up getting infected by the end goes down with R naught as well. So with an R naught of 4, we would expect about 98% of the population to be infected by the end of the outbreak. If R naught is 2, it would be about 80%. If R naught is 1.5, we would have 58% of the population infected by the end. So this is what it means to flatten the curve. It means to reduce R naught so that you're reducing both the total number of peak cases, so where things are in the peak of the epidemic, but also the total outbreak size of the number of people that are infected in the end. So if we have an example where R naught is equal to 3, which is on the range of what we are seeing for this particular virus, here's what we might expect where the outbreak would take off, and it would be mostly done by about 2 to 3 months. But if that outbreak size is larger than the capacity of our hospitals that could deal with those sick patients in those cases, then that's a real problem, because the peak number is going to, so everyone during this phase is going to potentially have a much higher risk of death because the hospitals aren't able to take care of them. And so the idea, so one particular strategy for controlling an outbreak might be to reduce R naught just enough so that you reduce the peak number of cases so that it's below what we can handle as far as hospital beds and ventilators and all those other supplies and doctors. So where does this line actually lie as far as capacity? That's going to depend on different communities. You might imagine it would be different for New York City than it might be in a rural area. And so Erin is actually going to talk about some of this later, trying to get the data from Montana and what we would expect the capacity of hospitals to be. But this is one scenario, is to reduce R naught so that the peak number of cases lies below that capacity, so we don't get above what we can handle. But the thing about that is it also lengthens the amount of time that it takes for the outbreak to fully sweep through and end. But that's actually a good thing in the terms that it actually helps us prepare. So now we have several more months to prepare if we decrease R naught to get ready for those peak number of cases. So now we can stockpile those masks and get the ventilators ready and get ready for when things will get bad within a few months. So the goal of public health officials is to reduce R naught. So again, that's the average number of people that each person infects. So what determines what R naught is? So what that quantity is? R naught is the contact rate between people, how much people are contacting each other, how much they're coughing on each other, how much they're coming into contact with each other's respiratory droplets and surfaces that are contaminated, times the probability of transmission given contact. Not every contact with an infected person leads to an infection, and so we need to account for that. And then you multiply that times the infectious period. And so what that is how long a person is contagious. So so if you want to reduce R naught, you need to reduce one or more of these things. You need to reduce contact rates, probability of transmission given contact, or the infectious period. And so how do we do that? So for some other diseases, we have effective drug treatments. So for example, for the flu, we have a drug called Tamiflu that you can give to patients and help them recover more quickly. It decreases viral replication and people get over their sickness faster, and that decreases the amount of time they're contagious. Unfortunately, we don't have anything for that right now for this disease. There are a bunch of things that people are trying out and they're going through clinical trials, but at this point, we don't know that any particular treatment is effective and it's not really being used widespread at this point. So that's not as much of an option. The probability of transmission given contact, we can potentially affect with masks. If infected people are wearing masks, that's going to decrease that probability of transmission given contact. Hand washing will decrease that if you come into contact with contaminated surfaces. But the biggest kind of tool we have in our toolbox has to do with decreasing contact rates. And so you usually do this in several stages. The first thing that usually happens is we isolate sick patients. So if people are sick, isolate them away from all the other healthy people so they're not infecting healthy people. Then we can quarantine people who have had contacts with sick people but aren't yet sick, just to make sure that they can't spread to other people. We can close schools. So for a lot of diseases, we know that spread in schools is really important. We don't really know for this particular disease how important spread among children and in schools is. We can ban public events. We can go to that social distancing where we try to keep at least 6 feet away from each other. And then that stay-at-home order where we really try to decrease as much contact between people as possible. Stay home unless you absolutely have to leave. All of these things are going to decrease contact rates and reduce R naught. So one really important thing to think about is detection. So we're observing a number of cases and how it's changing over time, but this is only a fraction of the actual number of people infected. Because unfortunately, there's a limited number of tests available right now. It means that only the really severe cases are being detected, those where people have really severe symptoms. But we know that there are many cases which are less severe and even asymptomatic. So people don't know they're sick, but they're walking around potentially infecting others. A very rough estimate about what our detection probability is somewhere around 15%, but honestly, we really just don't know how many cases we're missing. But if we assume that the detection is about 15%, we're detecting about 15% of the cases. If we assume, so I'm thinking about Montana here, we have a population of about 1 million. So we might expect case numbers to look like this over time, where these are number of days since the first introduction. We might expect the spread of the disease to look like this if we do nothing. That's the total number of cases, but the number we actually detect will be much smaller if we only have a 15% detection. And that also means that we often miss the first few cases. So with this example, it's possible that we went 3 weeks before we detected a case. So the infection was actually here in Montana and spreading for up to 3 weeks before we ever detected it. So these are sort of best guesses right now on my end about what R0 actually is. So Erin's going to talk a little bit in a minute about some estimates from Montana, but we think it's somewhere between 2 and 3. So as far as the spread, this might be a little on the high end of what we would expect. But if we do nothing and let the disease spread, this is what we would expect, that 94% of the population of Montana would be infected by the time this thing's done in about 4 or 5 months. And we would expect more than 2,600 deaths. This is not assuming that we're exceeding the capacity of hospitals, which I know we will if we don't do anything. So that would be an optimistic number of deaths. So this is what we would expect if we didn't do anything, if we just let it go and weren't doing all these interventions. But we're doing a lot right now to try to reduce R0. We're doing the social distancing, we're staying at home, we're really reducing those contact rates, or at least that's the goal. So the question is it working? What effect are these things having? What effect is that stay-at-home order and that social distancing? Is it working? So if we fit a model, that SIR model, here's what we would expect things to happen over time with an R0 of 3. Here's the actual number of cases that we have observed in Montana going up to that stay-at-home order. So it fits pretty well to an R0 of 3. So then there was the stay-at-home order where everyone's been staying at home. We've reduced contacts between people. Is that working? Yeah, it really is. So the number of cases has really gone down. So that means that R is less than 1 now. So each person is infecting less than one other. And so the cases are starting to drop off. Whereas if we had done nothing, things would be really ballooning out of control by now. So we're in this phase of the epidemic right here, right now, where we look at things and we say, oh, it's not really all that bad around here. So we're making too big of a deal about this, but that's because we've done it right. That's because we got it right and we acted early enough to where things didn't get way up here before we started changing things. So basically this is showing that what we're doing is really working. Otherwise we would have way more cases than what we're seeing right now. So if we zoom out to if we had done nothing, we would expect it to take several more months for the outbreak to peak, whereas this is where we are so far. And it's barely a blip on what we would expect if we had done nothing. So Erin's going to tell us a little bit more about Montana specific kind of values for R, but this is what some groups, so Imperial College in London has been doing a lot of estimates of what's been happening in Europe. And they've been estimating R0 to be somewhere between 3 and 4 for most of these European countries. So for example, here, Denmark, the best guess is that somewhere about 3.2, But you notice there's this kind of, this bar here is indicating the spread, that there's a lot of uncertainty. So they think the R naught is somewhere around 3.2, but there's a lot of variability in what it could be. We're not really sure. So there's a lot of uncertainty in what's going on right now, and it's hard to really nail down a good estimate for R naught in a lot of places. But we would expect that Montana R naught might be a bit lower than what we're seeing for a lot of other places because our population density is lower. And so our contact rates are going to be lower. And so we might expect R naught for Montana to be a bit lower than what we would see here for these European countries. So what impacts do these different interventions have on that R? Here's an example of Italy, where it was estimated that in the beginning, before they did anything, that the best guess for R naught was around 3.5 to 3.7, so somewhere in this range. So the dark green is indicating what's kind of the most plausible values for R naught, and this is like, well, it could really be anywhere between here and here, but these are the most plausible values. So before they did anything, they were estimating R to be about 3.7. But then here at this point in time, they closed the schools, and they estimated that that decreased R by this much. And then they did public events ban, social distancing, and self-isolation. And then that decreased R even more. And so then when it came to a total lockdown, now they're actually reducing R below 1, and they've started to see a drop off of cases. So this is a broad kind of generalization of what's been happening in Europe. I'm going to now hand it over to Erin, and she's going to tell you about collecting data and making projections in the future specifically for Montana.
Great. Thank you, Angie, so much for your visuals and explanation of some of the different models that can tell us about the epidemiology of the virus. So we are now going to turn to Erin Semmens. Can you share more with us about strategies to protect healthcare, resource needs, and hospital capacity in Montana, and responses at the local level to flatten the curve?
Yes, I can. Thank you, Jennifer, and thanks for inviting me to participate in this webinar. And I just want to mention right off the bat that I'm just one small part of a team who is involved in what I'm going to present today. So in addition to me, Erin Landguth, Ethan Walker, and Curtis Newman, all health sciences at the University of Montana. And so in thinking about expanding and building on the infectious disease epidemiologic principles that Angie talked about a few minutes ago, expanding upon those to inform public health policy and mitigate the impacts of the COVID-19 pandemic in Montana. And so how are this notion of R naught, how is it used in national models to tell us about projected resource needs and potential shortages in Montana? And I want to also cover some of the challenges about trying to apply those national models in a rural state like Montana, and provide one example of a model that's been developed, and it continues to be under development by Erin Landguth at and going through some of the features of that model. But then also in kind of zooming in a little bit on some of the local strategies that are critical to flattening the curve. So kind of thinking like higher level modeling efforts, and then kind of thinking what's going on at the local level to help mitigate the spread of the disease. And so I just wanted to go through the example of one national model. There are multiple ones out there, and sure you've heard about a number of them in the news or reading the newspaper. This example I'd like to show is an example from a group at Columbia University. It's from the Mailman School of Public Health. It's a group led by Jeffrey Shaman, and his group has developed this really neat kind of interactive website where you can zoom in on your location of interest. Here I've zoomed in on Montana, and you can specify a number of different, make a number of different assumptions, and then see, okay, well, what will happen? What's the potential for exceeding resource capacity in different counties in Montana under various assumption scenarios? And so with this example, I've put in when would we expect hospital capacity to be exceeded if there's no social distancing and a medium hospital surge response. So that's just kind of assuming hospitals prepare in kind of an average way. They have specific criteria for how they define a medium surge, but kind of preparing kind of an average way for increase in needs due to COVID-19. And so under this example, you can see the redder the county, the sooner resources will be exceeded. But we know that in Montana that we've had a stay-at-home order for some time now. So this isn't reality. So this has not been our experience in Montana, fortunately. And so here is the next slide is an example of, okay, well, what if you change these assumptions? What if you say instead we're assuming 20% social distancing in the same hospital surge response, and then so we see only one county coming up as red. But again, this isn't reality either. This is assuming a 20% social distancing, so a 20% reduction in contacts with the stay-at-home order. So this is also not quite real. But you can go to this website, and I've included the link here, and change different parameters, and you can also do this for different types of healthcare resources. This is just one model of many. I'm sure you've heard about the University of Washington's IHME model, the COVID model. There are multiple models out there, and I think it's just really one of the take-home points I hope you kind of take away from this is that it's important to look at multiple models. So use a multiple model framework to compare and evaluate kind of the range of possibilities. So no one model is going to be perfect. No one model is going to be exactly right. And no one model is a crystal ball on what's going to happen in the future, because we don't know, because human behaviors will have an impact on what actually happens in policies and development of treatments or vaccines, et cetera. And so, but one thing that a lot of these models do, and one of the challenges in applying them to Montana, is they use some national estimates or data sources for hospital bed capacity in the state of Montana that might not reflect what's actually available, or what's actually available within a reasonable distance for someone who develops COVID-19. And so Erin Langus, specifically in our group, has been working furiously over the last 2.5 weeks to develop a Montana specific model. And so you can see here, Angie showed earlier some estimates, some R-value estimates from different countries. And you can see in Montana, these are looking a little bit lower. And so it's about mid-March where this graph starts. And it's the estimate's above 2, and it kind of bounces around a little bit before it starts to go down. And Angie mentioned kind of that magic 1 number for the R value, where if it goes below 1, then eventually, without any other source coming in, the transmission will die out. And that is all good news and encouraging, and gives us some reassurance that these social distancing measures that have been implemented in Montana have been effective. And so just to talk a little bit about Erin's model. So Erin is really the mastermind and the heavy lifter behind everything I'm going to show in the next few slides. So Erin has projected hospitalizations in the state of Montana related to COVID-19, as well as intensive care unit bed needs and ventilator needs. And so I'm just going to show here the example for projected hospitalizations in Montana. And so Erin has made projections under 4 different modeling scenarios. So the blue line assumes that the stay-at-home order will be lifted on May 9th. The black line assumes that it will be lifted 2 weeks after that, May 23rd. And then the green and the orange lines are sort of the more idealized or longer in duration social distancing scenarios. So the green assumes social distancing all the way until the end of October, and the orange assumes a very, I would say, kind of more complete social distancing. So more of kind of like a lockdown scenario where we see a really steep decline in the R naught, or in the R value over time. And one point I'd like to make is that as the stay-at-home order is lifted, if it were lifted on May 9th, for example, we aren't assuming, this model does not assume that we're going back to normal. So stay-at-home ends on May 9th, and then we go back to living our regular lives, kids back in school, all of those things. This model assumes a loosening of restrictions, not an end to restrictions. And so this curve would look very different if we were saying, okay, we're gonna go back to normal. And so you can see the earlier, with the earliest ending of social distancing, then the projected hospital beds needed is higher. And so this is for the entire state of Montana. I'll note that. Erin's also developed projections for different hospital regions in Montana, as well as county level projections. And then it's lower, but relatively similar under the distancing to ending on May 23rd. And then those green and orange lines are more similar. On the right here, you can see the projected hospital beds needed at the peak date. So in this plot on the left, we don't see the peak. We see the curve going up, but we don't actually see a peak. And so the mean under the scenario where social distancing restrictions are lifted on May 9th, the mean hospital bed needs on that date is 314 beds. And so you can see the means using the black bars under the various modeling scenarios. And there are assumptions in these models, of course. And so one thing is you assume what the hospitalization rate is for an infected patient. And so Erin does some sensitivity analyses to see, well, how do needs change if I sort of alter that hospitalization rate, and don't assume that it's, I allow it to vary somewhat. And so that's what those min and max bars refer to. And the point I made earlier, that it's important to consider multiple models when considering how these projections should inform policy, because there is no perfect model. I'm not a modeler, but in talking to modelers and in reading about their views and listening to their interviews, they all really say the more the merrier, because the more the merrier when it comes to high quality projections. I should qualify that. And the reason is because each model has different assumptions. Some models have different assumptions for R naught, for example. So in this plot, this shows projections using a number of different modeling approaches. So the black line is the projection from the COVID Act Now model. Some of these lower lines are from the University of Washington IHME model, and then Erin's model, the projections are somewhere in the middle. This yellow line and this teal line down here under different modeling scenarios. And as I mentioned earlier, they have different assumptions, different strengths, and some are better suited to more urban areas. Some are more difficult to apply in a rural state where maybe we don't have a high number of deaths from COVID, fortunately, at this point. And so, and then the last point to reiterate, which I mentioned earlier, is that these are not forecasts for the future. The policies that are made and human behavior will have an impact on the reality, or what actually happens. And so Erin's models are constantly being updated in collaboration with our team and with collaborators at the Montana Department of Public Health and Human Services. And so what I showed you earlier was one was the most recent run, but they're always being updated with new data and with new information about the best way to model disease transmission in the state of Montana. But ongoing work to really refine the model to best project resource needs in Montana is to incorporate additional data sources that we have access to better predict how people move from those S to the I to the R boxes that Angie talked about earlier. So a number of factors might have an impact on whether a susceptible person becomes infected or an infected person needs to be hospitalized, for example. So some of those factors might include population density or the neighborhood social environment. And so that's one factor that we are starting to look at and to assess at the county level in Montana. Race, ethnicity might also be important to consider. And the other another approach Erin's actively working on right now is to really try to evaluate the healthcare resource needs in the context of the capacity that we actually have in Montana. And so she is looking at where patients are actually going, looking at the service areas for the various hospitals that would treat COVID patients in the state of Montana. And that's an ongoing, those are ongoing efforts right now to really get a better estimate of when we would exceed capacity due to COVID-19. And I think it's really important. These models are useful and incredibly valuable in terms of projecting needs and potentially exceeding our capacity at hospitals in the state. But another way, and they're also useful for evaluating the impact of policy interventions. But another very critical way to evaluate interventions and to mitigate the impact of the pandemic is the local response to COVID-19. And so these are your classic epidemiology outbreak investigation tools to do this. And so this involves testing people, interviewing cases to characterize them in terms of person, place, and time, isolating cases, tracing their contacts, and quarantining those contacts, and all with the goal of limiting the severity and the scale of the ongoing epidemic and to prevent future outbreaks. In addition, evaluate the success of interventions. And so here is an example of an epidemiology, an epi curve put together by a postdoc, Ethan Walker, in our group. We've been collaborating with the Missoula City County Health Department. And this just shows the cases over time by date of onset. And so each box represents a case. And so you can look at what this curve looks like over time, and then you can put markers in for when were the bars and the restaurants closed, when were schools closed, and then look, incorporating some lags, what has happened to the curve after those policies were put in place. And then again, you can look at these curves by various factors that might have an impact on severity of disease, for example. And just to make sure we have enough time for questions, I wanted to just end with the kind of the massive response to this epidemic in Missoula County, and just kind of the all hands on deck approach to try to mitigate the impact of COVID-19. And our group's happy to participate in a small way in this effort. And with that, I'll wrap up and look forward to a good discussion. Thanks.
Wonderful. Thank you so much, Erin. That was a lot of great information. Those are some really fascinating models, and I'm looking forward to the great questions we're going to have that might get answered from some of that content. Okay, so folks, we are now entering into the question and answer phase of our webinar. So at this point, if you have a question that you would like to ask our panelists, you can use the Q&A button in your Zoom app to ask the question, or you can type it into the chat box. Some of you did ask some questions earlier during the webinar, and I have copied those over so that we can get started with asking some of those questions. So I'm going to start with one that was asked at the very beginning of the program, which is why are the number of people infected, why does that decrease with a decrease in R naught? And this came up while Angie was presenting. Could you do this one for us?
So if I understand the question right, so R naught tells you about how many people does each person infect? So if there's an R naught of 2, I'm going to infect 2 people. Those 2 go on to infect 2 people. Those go on to infect 2 people. And so we're going to end up with an outbreak that's changing over time. If R naught is 3, then then it's going to spread much faster because each person is infecting 3 others, and things are just going to really increase really quickly. So can you tell me the wording of the question again? I'm not sure I answered it yet.
Sure. The question was, why number of people infected decrease with decrease R naught?
So then it's just thinking about things in the opposite direction. If you decrease R naught, so like let's say we decrease contact rates, and now we've decreased R naught from 3 to below 2, that means that in the beginning, an infected person was infecting 3 others, and they were infecting 3 others. But if once you reduce that to 2, now things are going to slow down a lot more. But they're not going to fully drop off until you get that R value, or R naught below 1, because that's the critical threshold of which you're not really replacing each infection. So one person would only infect 1 other or less than 1 other, and then you're going to get a drop off of cases after that.
Great, thank you. Okay, we have another comment here, a question. If the virus continues to mutate, then will it become entrenched in our communities permanently? Anyone like to answer this one?
I think Brandon maybe should take.
Brandon, thanks for joining us. Would you like to take this one?
Yeah, sure. So this virus is transmitting really well now. Like, it's doing fine. It's in a population that's really susceptible, and it's transmitted by asymptomatic people. So it's going to be with us for a period of time, until, at some level, until a vaccine or therapeutics or other things like that. When we think about mutation, these things are error prone and have relatively high mutation rates, although the last estimates I saw for SARS-CoV-2 here is that it is it's lower than mutation rates you see, say, for seasonal flu. The things I would be thinking about for mutation in terms of that specific question is, if you're going to get the type of mutations that lead to it making difficult to have a vaccine that the virus sort of doesn't outrun. The people that are working on that are pretty optimistic that those sorts of things aren't going to happen in the time scale at which they're developing the vaccines. And so I think the question is whether or not, if that does happen, the rate at which it happens, and then how that scales with the ability of us to keep up with it. But in general, people seem to not be too worried about that, relatively speaking.
Okay, great, thank you. We've got a few more questions here. Did the models predict an ideal time to remove or reduce social distancing measures? Erin, you want to answer this one?
This is the crystal ball question that is, and I'm not going to have a satisfying answer to that question. No, they don't, but they show us the range of possibilities under different scenarios. And I think we're going to have to wait to see what happens in other places around the world and around the country, as what happens when they slowly loosen restrictions. And so then we can see what's happening to the R value, how, and then kind of piece by piece, bit by bit, sort of safely loosen restrictions. So I think the short answer is we're not really sure. We have the benefit of being able to be a bit behind where other folks are, in a good way, so we can learn from what's happening elsewhere.
Great. Okay, here's another one. There is concern about history repeating itself. When the influenza pandemic happened, there was a second wave that affected more people than the first. What is the possibility of this happening?
I guess I'll try, and then other people can butt in here. That's with what's happening right now, that's actually fairly likely, yes, because we're working really hard right now to bring R naught down. And as you can see from some of my figures, we are bringing it down. We acted early, we're bringing it down, but as soon as we lift the restrictions, things are going to increase again. And that's going to happen until we get either we get a vaccine, or we get really good, we have much better testing. So if we had way more tests than what we have now, we could test everybody, even people that aren't showing symptoms, to make sure that we detect infections very early and then do contact tracing, talk to everybody that they've been in contact with, isolate them. And then we might be able to do a good job of keeping things down until we get a vaccine. But as of right now, we don't have very good testing. And so lifting the restrictions before we have good testing is likely going to lead to an increase in cases. And so there's a couple of different scenarios which might happen in that case. And I think we're going to talk more about that next week. Isn't that what we're going to do, guys? Okay.
Either Brandon or Erin, did you want to jump on that one at all? Add anything?
Well, I would just say that we don't know, obviously, but I think we're all really worried about that, mostly because if you think back to what Angie was talking about, that model, because we've done such a good job, we're sitting with a population, presumably, that is still almost fully susceptible. So it feels like, and we have done a lot of really good work, but this is one of those things where sort of the better the work you do, the more susceptible people that are going to remain in this case. And remember that we're doing that to try and lengthen the time that this happens. I fully expect that sort of thing can happen. I mean, what I'm worried about is that we all get tired of this, we come out and we don't do it in a very careful way. And then all of the work we've put in is lost, and we find ourselves in a position where we have to maybe decide to go back to social distancing in the fall. Certainly possible.
Great, thank you. Can you explain further why rural states seem to have lower populations of the infected? Is it primarily due to greater social distance, lower contact rates, or are there other factors?
Yeah, so R naught is contact rate is a huge part in that. And this is one of those diseases where we call it density dependent transmission, meaning that if the population is more dense, there's a high population density, you're just going to contact each other more. So in New York City, there's just a lot more contact between people than there is between people around here in Montana or Wyoming. And so the contact rates in general, just by default, are higher in some places that have higher population densities. And so that's going to mean that R naught is higher. And that's going to mean that you're going to get a bigger outbreak in places where there's a higher population density.
The only thing I would add to that I've heard some people asking questions about related to, and we'll talk, I think, next week some about, is, well, why would you, with so few cases in a rural area, employ the same strong strategies for social distancing? And that has to do with, what are you trying to flatten the curve below, like Angie showed, where that line actually is. And if you live in a place with only, 10 cases, but you don't have a hospital nearby or you don't have ICU beds, then it's a totally different goal that you have there, because, you need to really flatten that curve.
Great. I'm actually going to jump back next to a question that's kind of similar to this, but looking instead of at rural states, looking kind of at countries around the globe. We had someone ask earlier on in the program, are there estimates of R naught for various countries with COVID-19? So are there different R naught values or estimates from one country to another right now?
Yeah, so I showed a few of those estimates from Europe, and there are some countries like Switzerland, it was significantly higher than what they were seeing in Denmark. Some of the R naught estimates that are coming out of China, there's a lot more questionable, like we've seen estimates from anywhere from 2 to 6. So there's a lot more uncertainty there. I think it's, things were, it was very early on in the whole thing. But so what we're seeing here for like some of the estimates that Erin was giving you, just above 2, is within the range of what we're seeing for some other countries, but it's a bit lower than what we're seeing for places that have higher population densities. Like for Europe, they ranged anywhere from a bit above 2 to above 4.
Great, thank you. We have a question here about the vaccine. Is it possible to predict whether the vaccine will be something that has to be given annually versus a one and done situation? Kind of like we have the annual flu vaccine versus a one-time vaccine for MMR or DTP, things like that.
You want to take that, Brandon?
I think it's a great question. I hesitate to answer it because I just don't feel like that I know enough to do that. I think in some sense it'll take a little bit of time to figure that out. But I'm sure if you had a vaccine specialist here, that they might know generally, you know, for coronaviruses, we would expect something different. I mean, I would just say that the evidence is so far that prior to this, that generating vaccines of any sort for coronaviruses is different than the flu and quite challenging. And so, yeah, I don't feel confident predicting that out just because I don't have that information, and I'm not sure that we have enough to say it confidently.
Just to add on to that, I actually recently heard a story on NPR that talked about some research being done into creating a kind of vaccine for these type of viruses that would be kind of a one and done situation where you'd only have to give it once and it would cover all the flu-like or corona-like type viruses that have ever been and that ever would be. And I guess I'm just curious as well, with the research and the expertise and the knowledge that you have about how this virus is being dealt with and how vaccines are being created, what are the chances of something like that being realistic?
My answer is sort of the same in that I don't think I have enough good information to do it, but I would generally, if someone said that to me, I would be quite skeptical until I've seen it. I mean, that's obviously something that would be great, but yeah, I can't speak on the chances of that happening beyond saying I'd be surprised if we see something like that on a timescale that matters for the initial COVID spread.
Great. And I think that makes a really good point, is even if those things can happen, the timescale that we need it to happen is now, and it probably wouldn't be ready in the time that we actually need it right now. Okay, we have another question here. Is it, what would you say to a loved one that thinks that the economic effects are more detrimental to all of us than the effects of the virus? Juicy question.
Yeah, tough, right? That's a tough question to answer because I don't think obviously there are lots of consequences of the economic problems that can stem from this. I don't think any of those are a good argument to pull back and let these things exceed our healthcare system. So, you know, from my position, it's absolutely true that the economic things are bad, but my response to it would be that we should be working really hard to flatten the curve and expand hospital capacity in ways that enable us to try and have some sense of normalcy. But for clarity, I mean, I think, and we'll talk more about this next week, I mean, moving forward for a while, we're probably at best going to have some sort of hybrid model where large events, you know, still aren't open, and places that do open are going to still employ social distancing and all that sort of stuff. So I think it's still going to be a compromise. I mean, it would be absolutely awful to just release everything and get fully active. It would waste everything we did, and we would be making a decision that we knew was not only going to result in death, but that it was going to result in the death of specific people that we already know, groups that are more susceptible now. So I just think on a very basic moral level, it's not possible.
Great, thank you. I'm going to jump back here to a question about R0. So if R0 decreases, the recovered/immune group also decreases, meaning more people continue to be susceptible. Is that correct?
That is true. However, if R0 remains at that low level, then you end up having what we call herd immunity, which is a complicated kind of concept, which I had planned on talking about next week, because next week we're going to talk about sort of what we would expect on the longer term. So we might get at some of these other questions that have been asked recently, or at least delve into them a little bit more. But the idea is, if you have a really high R0, the proportion of the population that would need to be in that recovered class is going to have to be a lot higher in order to eradicate the disease than if you had a lower R0. So you wouldn't need as many people in the recovered class. You could have a lot more susceptible people if you have a lower R0. It's a complicated subject, and I'll hopefully be able to get at it next week a little bit better.
Great, thank you so much. Well, we are nearing the end of our hour, and before we finish and close out, I wanted to ask any of the panelists if there are any final thoughts or words they'd like to share before we close, and I can give you some more information about what to expect next week. Great, awesome. Okay, well, thank you to all of our viewers today. We had some great questions, and we'll continue the discussion next Friday at 3 p.m. Mountain Standard Time. A recording of this webinar and the previous week's webinar will be available on the Montana Natural History Center website. Our co-host Drew will drop that into the chat box so that you can link directly to it if you'd like. Next week, we're going to be transitioning into discussing uncertainty in the new normal of social distancing and what the future may hold in this new reality. Thank you so much to all the panelists. Thank you, Erin. Thank you, Brandon. Thank you, Angie. Thank you to our closed captioning expert, Caroline, out there. Thank you to co-host Drew, and also to Glenna. She's been managing our Facebook live stream of our webinar today. And thank you to the University of Montana and the Montana Natural History Center for this partnership in our new webinar series, The Age of the Coronapocene. Everybody have a safe and fun, socially distanced weekend, and we will see you all next week.
Thank you.